Hello, and welcome to our program, RSV and the Older Adult, Much Ado About Something. This program is supported by an educational grant from Janssen Therapeutics, Inc., a division of Janssen Products, LP. Before we get started, please take a moment to let us know who you are and answer the pre-test poll in the tweets below. Tweets, also including details regarding how to obtain your free CME credits, are available. Be sure to watch our handles for additional RSV CME programming and follow Bonham CE for more CME certified programs on Twitter. I'm Dr. Michael Ison, a professor of infectious diseases and organ transplantation at Northwestern University's Feinberg School of Medicine. Today, I'm joined by my colleagues, Dr. Steve Varga and Dr. Hannah Nam. Steve?
Good afternoon, everyone. I'm Steve Varga. I'm a professor of microbiology and immunology and associate dean of academic affairs and graduate student development in the Carver College of Medicine at the University of Iowa.
Hi, I'm Dr. Nam. I'm assistant professor and the director of transplant and immunocompromised host infectious disease here at the University of California, Irvine.
On this slide, you can see our disclosures. Next, I'd like to talk about what our learning objectives in this session are. Upon completion of this educational activity, participants should be able to elevate awareness of respiratory syncytial virus, or RSV, and underestimation of detecting RSV infection diagnosis, as well as morbidity and mortality in people over the age of 60. Select strategies to identify and diagnose at-risk patients, to differentiate diagnostic factors for patients at risk for RSV, to describe recommended diagnostic testing to identify patients at risk for RSV infection, and lastly, to identify strategies to prevent exacerbation of RSV infection that contribute to increased morbidity and mortality. As we move on, I'll hand it over to Steve.
All right, so we're going to begin our presentation by a discussion of the epidemiology of RSV. So RSV is among the most common causes of acute respiratory tract infection in adults worldwide and a common cause of bronchiolitis and pneumonia in young children. It is, however, increasingly recognized as a significant health concern for older adults and those who are immunocompromised or at severe risk of disease due to underlying health conditions. Notably, RSV is generally not considered an important health threat to adults for several reasons, including diagnostic challenges, underreporting, and underappreciation of the actual burden of RSV on adults. RSV was reclassified in 2016 into the family of Pneumoviridae. It is a medium-sized pleomorphic enveloped virus with a non-segmented negative-sense single-stranded RNA genome that encodes 11 proteins, including 2 non-structural and 9 structural proteins. The G, or attachment protein, the F, or fusion protein, and the small hydrophobic, or SH, are hydrophobic transmembrane surface glycoproteins that play key roles in infection transmission. These 3 proteins are also the focus of protective antibodies and may be potential targets for therapeutic interventions. RSV isolates split into 2 major antigenic groups known as A and B. Group A consists of 13 RSV genotypes, while B consists of 20 RSV genotypes. The primary genetic difference between A and B is located on the G protein and accounts for approximately 50% of the genetic differences between the 2 genotypes. Both A and B strains can circulate at the same time during an outbreak, but the proportion of cases that are attributed to A and B varies each year, as does the subtype within the 2 groups. RSV replicates almost exclusively in highly differentiated apical ciliated cells of the airways, which primarily causes superficial damage to the lining of the airways. This damage establishes conditions that predispose the individual to secondary bacterial infections. The damage also creates a mechanism that allows the virus to evade systemic immunity because the virus avoids exposure to dendritic cells that are responsible for transportation of RSV antigen to the lymph nodes. Increased viral loads are thought to lead to an increase in neutrophilic inflammation of the upper and lower respiratory tracts. The severity of disease is thought to be associated with the degree of resulting inflammation. The protection and clearance of RSV are mediated by neutralizing antibodies and cytotoxic T cells. Both serum IgG and mucosal IgA antibodies are involved in protection against subsequent RSV infection. However, RSV evades or suppresses B memory cells in humans and suppresses the development of mucosal IgA memory responses in adults. Both anti-RSV IgG and IgA titers wane rapidly over time in humans, with more than 75% of adults showing a fourfold reduction in neutralizing anti-RSV IgG titers within a year after natural RSV infection. CD8 T cells are essential for clearance for RSV infections. Of note, deficiencies in CD4 and cytotoxic CD8 T cells in patients with severe combined immunodeficiency, allogeneic stem cell transplantation, or lung transplantation places these patients at higher risk for RSV infection. In addition, older adults appear to shed RSV for longer periods at higher titers, which also suggests impaired cellular immunity. Following RSV infection, immunity diminishes over time, placing patients at increased risk for recurrent infections. In order to characterize the risk of RSV infection in adults, 15 adults were rechallenged with RSV of the same strain group A, at 2, 4, 8, 14, 20, and 26 months after a natural infection. At 2 months, about 1/2, and at 8 months, 2/3 of the subjects had been reinfected with RSV. Each challenge resulted in infection in at least 25% of the subjects. Within 26 months, 73% had 2 or more, and 47% had 3 or more infections. The duration of immunity tended to increase after 2 closely spaced infections, and higher neutralizing F and G antibody levels before challenge correlated significantly with protection against infection. There's also seasonal variation in the circulation of RSV, with temperate climates such as the United States experiencing most outbreaks during the winter and spring months. Peaks are likely to occur during December and January. Tropical and equatorial regions of the world are more likely to experience RSV outbreaks during hot, humid, and rainy days of summer. There are less pronounced peaks or spikes in the circulation pattern and more interseasonal spread of the infection. Generally, one of the 2 genotypes will predominate during a single season, and they alternate annually with regional variations. It is not yet clear if RSV genotype predicts virulence and severity of infectious outbreaks due to conflicting findings from RSV research in pediatric populations. The Center for Disease Control and Prevention tracks patterns of RSV circulation for each year through polymerase chain reaction, or PCR, laboratory detections reported to the National Respiratory and Enteric Virus Surveillance System. Trends in RSV seasonal duration and peaks can be examined for the US overall and specific regions. As shown here, results for the US overall from July 2014 through June 2017 indicate that the median RSV onset occurred in mid-October. Median duration of the season was 31 weeks, lasting until mid-May, and the median peak occurred in early February. Of note, these findings suggest that the median national peak occurred earlier and the duration of RSV circulation was longer based on PCR testing versus antigen-based tests that were used for previous years and reporting cycles. There were also notable variations in median onset, duration, and peak when examined across 10 Health and Human Services regions, with median onset ranging from mid-September to early December, median duration ranging from 22 to 37 weeks, and median peak circulation ranging from late December to mid-February. RSV largely disappeared in 2020, owing to precautions taken because of the COVID-19 pandemic. A simulation modeling study was conducted by Zhang and colleagues to examine the association of different factors, including mitigation strategies, duration of maternal-derived immunity, and importation of external infections with the dynamics of reemergent RSV epidemics. Mathematical simulations projected the trajectory of RSV epidemics from 2020 to 2025 based on different scenarios that manipulated the stringency of mitigation measures for SARS-CoV-2. These simulations also assessed factors that were thought likely to affect the reemergence of RSV epidemics. Not surprisingly, the incidence of RSV declined in most of the US since the introduction of mitigation measures for COVID-19 in March 2020. There was a low rate of RSV positive cases in the fall and winter of 2020 to 2021, and a similar decline was reported by most countries worldwide. With the easing of mitigation measures, different patterns of RSV epidemics emerged in different regions of the world. For example, there were small spring and summer waves of RSV in France, Spain, and many US states. However, large out-of-season surges in RSV were evident in Australia, South Africa, and several southern states in the United States. Based on results from the simulation modeling efforts, it is predicted that RSV epidemics for the next several years will be more intense and affect patients in a broader age range than what usually occurs during a typical RSV season. In addition, the timing of RSV outbreaks may differ from the usual RSV season, depending on the duration and extent of mitigation measures, as well as the extent of virus introduction for regions of the world. Transmission of RSV occurs through dissemination of large nasopharyngeal secretion droplets by an infected individual. These droplets enter the eyes, nose, and mouth following a cough or sneeze, or by touching a surface that has droplets on it, such as a doorknob, and then touching the face before washing the hands. Large particle aerosols may transmit within a radius of 3 feet. RSV can also be transmitted through direct contact, such as by kissing a child who is sick with the virus. RSV can survive for approximately 24 hours on hard surfaces, such as tables and crib rails, while it typically lives on soft surfaces such as tissues and hands for shorter periods of time. The risk of transmission varies by the target population and care settings. A recent systematic review of the published and unpublished literature from hospital settings examined the risk of nosocomial RSV transmission during outbreaks and the effectiveness of infection control measures. 19 studies addressed the questions of RSV transmission risk, including 5 that focused on adult patients. The transmission risk ranged from 5.6 to 12% in 3 studies of adult patients who were receiving care in hematology and transplant units. Among adults in other inpatient settings, the risk of nosocomial transmission ranged from 29.6 to 32%. Multi-component interventions were used to prevent the transmission of RSV, including cohort nursing, personal protective equipment, and isolation, and these were found to be effective for the reduction of nosocomial transmission. RSV typically manifests as an upper respiratory illness with the possibility of lower respiratory tract involvement. Clinical presentation differs based on the location and severity of disease. If limited to the upper respiratory tract, RSV typically presents with rhinorrhea and nasal congestion in 22 to 78%, or sore throat in 16 to 64%, sneezing, and sometimes fever and myalgia. When the lower respiratory tract is involved, the clinical presentation will be characterized by bronchiolitis, including rhonchorous breath sounds, tachypnea, accessory muscle use, wheezes, and prolonged expiration. Cough is estimated to affect 85 to 95% of patients, wheezing 33 to 90%, and dyspnea 51 to 93%. In several cases, patients may also present with findings of viral pneumonia, hypoxia, lethargy, apnea, and acute respiratory failure. Radiographic studies with computed tomography commonly show pulmonary nodules and ground glass opacities, and standard chest radiographs may show changes consistent with pneumonia. In general, RSV is not clinically distinguishable from other respiratory viruses, including influenza. A laboratory-based epidemiological study assessed the prevalence of RSV and other respiratory viruses in samples collected during the first surveillance year of the Influence 65 clinical trial, which was conducted in 3 continents. Shown here is a comparison of the frequency of symptoms in patients with RSV and influenza. Influenza had a higher frequency of fever at 72.4% compared to only 56.4% in RSV. RSV was more likely to present with symptoms of dyspnea, 51.3% versus 32.7% for influenza, and wheezing, 46.2% versus 30.6% for influenza. Morbidity and mortality are significantly higher in selected groups of adults, including patients with pre-existing cardiac, pulmonary, neurologic, and immunosuppressive disorders, and the elderly. Adults admitted to hospital and infected with RSV more often have underlying chronic lung diseases, 35.6% versus 24.1%, than do patients infected with influenza. Importantly, RSV frequently exacerbates diseases that affect the airways, such as asthma and COPD. Patients with multiple comorbidities, for example, COPD and congestive heart failure, are more likely to develop symptomatic RSV illness. In addition, cardiovascular disease is associated with an increased risk of RSV, with an estimated 45 to 63% of adults admitted to hospital with confirmed RSV. RSV is also associated with exacerbation of cardiovascular conditions such as congestive heart failure, arrhythmias, acute coronary syndromes, and myocarditis. Risk of severe disease and mortality from RSV is greatest among recipients of HCT and lung transplants, as well as patients actively undergoing chemotherapy for leukemia and lymphoma. In general, RSV is not clinically distinguishable from other respiratory viruses, including influenza. A laboratory-based epidemiological study assessed the prevalence of RSV and other respiratory viruses in samples collected during the first surveillance year of the Influence 65 clinical trial, which was conducted in 3 continents in the Northern Hemisphere. Study participants were community-dwelling or residents of retirement homes. Nasal throat swabs were collected for 88.8% of moderate to severe influenza-like illness episodes reported during the first surveillance year of the Influence 65 study. RSV was detected in 41 of 556, or 7.4%, of moderate to severe ILI episodes. Most were single infections, 39 of the 41. The frequency of individual respiratory symptoms showed no pattern of symptoms that was associated with virus type. A wide variety of factors are thought to contribute to the increased susceptibility of the elderly to respiratory infection, including RSV. A key factor is the high prevalence of comorbid health conditions. Additional factors include dysregulation of the immune system that is associated with aging, poor nutritional status, polypharmacy, age-related changes in lung function and physiology, decreased physiologic reserve, impaired mobility, and decreased levels of physical activity. Elderly patients in long-term care facilities are particularly vulnerable and are often frail and have underlying chronic diseases, complex health needs, and a requirement for medical support. Diminished protection from vaccines may also play a role. RSV is a major cause of respiratory viral infection in patients with hematologic malignancies and those undergoing HCT since the 1980s. Estimated for the US alone suggests that 30 to 37% of respiratory viral infections in these patients are due to RSV, and approximately 19 to 36% of these progress to lower respiratory tract infection. The true incidence of RSV infection among HCT recipients is reported to range from 5 to 49%. This variability in rates is due in part to symptomatic patients diagnosed with different laboratory assays such as RSV antigen detection, identification of RSV by direct fluorescent antibody, viral cultures, and molecular assays in recent years. When incidences are based on molecular assays such as multiplex polymerase chain reaction, the range is 8 to 30%. Notably, the proportion of RSV infections causing lower respiratory tract infection in HCT patients ranges from 30 to 60%, with higher rates reported in earlier years in the early 1990s. 2 recent reviews examined the impact of RSV as a risk factor for progression to lower respiratory tract infection and those for mortality in adults undergoing hematopoietic cell transplant and those with hematologic malignancies. The first sought to identify risk factors for the risk of progression to lower respiratory tract infection in HSCT and hematologic cancer patients. The investigators developed an immunodeficiency scoring index, or ISI, for RSV based on combination of multiple host risk factors. The index included 6 factors that allowed stratification of patients into low, medium, and high risk for progression to lower respiratory tract infection, including neutropenia, less than 500 neutrophils per mil, lymphopenia, less than 200 lymphocytes per mil, age of greater than 40 years, myeloablative therapy or stem cell transplant within 1 year of infection, graft versus host disease, steroid use within 2 weeks of infection, and prior stem cell transplant. Additional risk factors were a history of tobacco use, hypoxia, nosocomial infection, matched, unrelated donor, mismatched donor status, and stem cell source. A second review examined risk factors for mortality due to RSV in patients undergoing HSCT. The authors reported that RSV-related mortality rates range from 5 to 43%, and risk factors for mortality include older age, male gender, bone marrow and cord blood as transplant source, corticosteroid use, lower respiratory tract infection, and oxygen requirement. A population-based study was performed in 35 countries in 7 sites in the US during 2 respiratory seasons from 2015 to 2017, from October 1 to April 30th, to quantify the rate of RSV-associated hospitalization in adults by the presence or absence of congestive heart failure. 2,042 hospitalized RSV cases with CHF status recorded were identified. 1,230, or 60.2%, were greater than 65 years of age, and 28.3% had CHF. Hospitalized RSV cases of CHF were older, with a median age of 76 years versus 67 years, and were more likely to have COPD, 39.9% versus 29.1%, and be obese or morbidly obese, 41.6% versus 35.5%, compared with hospitalized RSV cases without CHF. A lower proportion of adults with CHF had an immunocompromising condition, CHF 17.2%, no CHF 26.1%. A higher proportion of cases with CHF were admitted to the ICU, 24.5% versus 18.6%, and a higher proportion died during hospitalization, 7.8% versus 3.8%. When stratified by age, less than 65 years versus greater than 65 years, in both age groups, those with CHF had higher rates of RSV hospitalization than those without CHF. The highest rates were in adults greater than 65 years of age with CHF, 40.5 per 10,000 of population. Overall, for all ages, there were 23.4 additional cases of hospitalization with RSV per 10,000 population among those with CHF compared to those without CHF. Adults with CHF had 8.1 times the rate of RSV hospitalizations compared with adults without CHF. When stratified by age group, in adults greater than 65 years with CHF, the rate of RSV hospitalization was 3.5 times that of adults without CHF. In adults less than 65 years with CHF, the RSV rate was 14.3 times the rate in adults with CHF. And with that, I'd like to turn it over to Dr. Nam to discuss burden.
So in this section, we will be discussing the burden and impact of RSV on adults. We'll go through a few studies that describe the risk factors for severe RSV and then outcomes for those with RSV as well. So as Dr. Varga noted before, the epidemiology of many of these respiratory viruses really shifted post-COVID. And so much of the data presented here is from before COVID. Just in the US annually, RSV in adults age 65 and older accounts for 177,000 hospitalizations and 17,000 deaths. The table you see on this slide is a recent systematic review and meta-analysis that was completed to identify all studies worldwide investigating the disease burden of RSV-related acute respiratory illness in adults over 65. In this study, the investigators estimated the community incidence, hospitalization rate, and in-hospital case fatality ratio of RSV-related acute respiratory illness in older adults. And then it was further stratified by industrialized and developing regions. These rate estimates were applied to population estimates from 2015 to calculate the global and regional burdens in older adults with RSV-related acute respiratory illness in the community and in hospitals for that year. So the number of in-hospital deaths due to RSV-related acute respiratory illness were estimated by combining the hospital case fatality ratio data with hospital admission estimates from hospital-based studies. The study shows that in 2015 alone, there were about 1.5 million episodes of RSV-related acute respiratory illness in older adults in industrialized countries. The data for the developing countries were missing. And out of these, about 14.5% were admitted to hospitals. The global number of hospital admissions for RSV in older adults is estimated at 336,000 hospitalizations, and there's an estimated 14,000 in-hospital deaths related to RSV globally. And the hospital admission rate and case fatality ratio tend to be higher in those age 65 and above when you compare it to those age 50 to 64. This is a separate prospective seasonal cohort study conducted in Wisconsin, where RSV was shown to impact about 11% of their adults over 60 who were seeking medical attention for outpatient care due to respiratory symptoms. If you compare this to influenza, influenza constituted about 23% of the patients seeking medical attention. The RSV prevalence in adults tends to really vary depending on the year on the study, but it ranges anywhere between 5 to 18%. And several patients, 24% in this study that presented for care, had moderate to severe respiratory lower tract disease. And lower respiratory tract disease is defined as having at least 3 of the following lower respiratory tract symptoms or signs: cough, wheezing, or worsening baseline wheezing if you have wheezing to begin with, new sputum production, new or worsening shortness of breath, and tachypnea. If you are looking just at symptoms, RSV is clinically indistinguishable from other cold viruses. So this is the same Wisconsin study where the most frequently reported symptoms were sore throat, sputum production, cough, fever, dyspnea, myalgia, and wheezing. And this is consistent with most studies looking at RSV symptoms and epidemiology. In those who did have progression to moderate to severe lower respiratory tract disease, there were significantly higher rates of all symptoms except for sore throat, which was pretty much equal overall when you compare it to patients who did not have moderate to severe lower respiratory tract disease. RSV does tend to impact those with underlying comorbidities the most. Those who had progression to moderate to severe lower respiratory tract disease had a higher prevalence of COPD at 25% compared to 10% in those with mild disease, CHF at 19% compared to 6% in those with mild disease. The absolute frequencies when you're looking at asthma, diabetes, and immunocompromise were also higher for patients with RSV, moderate to severe lower respiratory tract disease. And overall, patients who do have RSV, moderate to severe disease, also have a significantly greater number of medical encounters in 28 days after enrollment. In this slide, we'll look at the severity of disease in the oldest old patients. So these are patients who are defined as age 85 and older. In this multi-center retrospective study of all of these oldest old patients, we're looking at those admitted with laboratory confirmed influenza and or RSV infection across 3 tertiary hospitals in Portugal, Italy, and Cyprus. And this is over 2 consecutive winter seasons, and we're examining the severity predictors in this patient population. The outcomes of interest in this study included pneumonia on initial presentation, use of non-invasive ventilation, and in-hospital mortality. A total of 251 patients were enrolled, and the mean age of patients included were 89, plus minus 3.9 years. And 79 or 31.5% of these patients were men. The most frequently reported comorbidities tended to be diabetes, COPD or asthma, CHF, and CKD, with CHF being the most commonly reported comorbidity at 47%. And the types of infections included influenza A, B, and RSV. As you can see, influenza A tended to be at the higher proportion at 56%, while RSV was still significant, 26%. In the same study, pneumonia was diagnosed based on X-ray and/or symptoms in about 33% of those at admission, and 9% of these patients required non-invasive ventilation, with only one patient who required invasive mechanical ventilation. Despite the lower number of patients who required mechanical ventilation, the study is striking in that it shows close to 14% of these patients experienced an in-hospital death. So in this multivariable analysis performed with age, gender, COPD or asthma, CKD for in-hospital death, and type of virus infection included as independent predictors for increased severity of disease in the oldest patients. And among all of these patients, the multivariable analysis revealed that COPD or asthma was the most significantly associated with pneumonia that was radiologically confirmed, or non-invasive ventilation. Both flu and RSV infections tended to be associated with non-invasive ventilation use as well. The morbidity and mortality of RSV tends to be underestimated when you compare it to that of influenza. This study is data presented from an observational retrospective cohort study conducted at Kaiser Permanente in Southern California, which is an integrated healthcare system with about 4.4 million members. So there is a large body of data with this study. This study assesses and compares the characteristics, comorbidities, healthcare utilization, and outcomes of hospitalized adults that were over 60 years old who tested positive for RSV or influenza between 2011 to 2015. There were a total of 645 RSV and close to 1,900 influenza-infected hospitalized adults in this study. And looking at an adjusted analysis, RSV infection, when you compare it to influenza, tends to be associated with greater odds of length of stay, more than 7 days, greater odds ratio of pneumonia, intensive care unit admission, exacerbation of COPD, and need for home health services following discharge. In the same study, again, this is a study in patients who are hospitalized and over age of 60. While the mortality during hospitalization and within 6 months of admission for patients with RSV does not differ significantly from those with influenza, the long-term mortality within 1 year of admission tends to be significantly greater in those with RSV compared to influenza at an odds ratio of 1.3. And if you look at the 1 year survival rate after admission, this tends to be significantly lower in those with RSV compared to those hospitalized with influenza at 74.2% versus 81.2%. This next study is a retrospective study looking at the same group, Kaiser Permanente, and the study also looks at the same population, those over age 60 and hospitalized for RSV. And pneumonia was diagnosed in 66%, with 21% requiring ventilator support, 18% admitted to the ICU, and the overall mortality was close to 6%. But the cumulative mortality, if you look at it over 1, 3, 6, and 12 months, tends to increase as well, from 8.6% ranging to 25.8% as you go out up to 12 months from the initial hospitalization. In the same study, there was an estimation of survival during the year following admission. This tends to be significantly worse in those who had advanced age and pneumonia during their hospitalization. So almost 1/3 of hospitalized RSV patients who are aged over 75 years died within 1 year of admission. And only approximately 40% of the patients in this age group were discharged home without the need for home health services. There were also many who required higher level of post-discharge care, which includes hospice care or skilled nursing facility care. If you look at the mid and long-term mortality trajectory through the 1 year following admission, this is most heavily predicted by advanced age, followed by the presence of long-standing chronic underlying medical conditions, including CHF, cancer, ESRD, and dementia as well. And in the same study, it's also shown that RSV infection tends to trigger pretty significant clinically consequential deterioration of underlying cardiopulmonary disease. 80% of the patients who had COPD or chronic bronchitis or emphysema at baseline experienced an exacerbation during their hospitalization. And approximately 50% of patients who had baseline asthma and 38% of patients with baseline CHF tended to have exacerbations as well. The worst 1 year survival of any subgroup was evident for patients with CHF exacerbation when they were hospitalized for RSV. And the number of this survival is approximately 57%. As shown here, the estimated survival during the year following admission was also significantly worse among those with CHF, but not really those with COPD, bronchitis, or emphysema. So despite the significant burden of RSV in adults, as discussed over the past few slides, there are studies showing that many of the discharge diagnoses tend to underestimate the overall impact of RSV. This is a study that was conducted from Rochester over 4 consecutive winters. Dr. Falsey and her team evaluated all respiratory illnesses in prospective cohorts of healthy elderly patients who are over 65 years old and in high-risk adults, and those include the ones with CHF or chronic heart conditions or lung disease, and in patients hospitalized with acute cardiopulmonary conditions. So a total of close to 2,500 illnesses were evaluated, and RSV infection, depending on the year, was diagnosed at 3 to 7% of these healthy elderly patients, but higher at 4 to 10% of high-risk adults. According to the diagnosis at discharge, interestingly, RSV was not the main diagnoses given to those even hospitalized with RSV. The most common discharge diagnoses instead frequently listed the sequelae of having RSV. This includes pneumonia, COPD, CHF, and asthma. This is despite the fact that even when you compare to influenza, the healthcare resource utilization of RSV infection is considerable. This is both in healthy elderly groups and in the high-risk group. So in this same study, in the healthy elderly group, 15% of patients called their physician, 17% required office visits. There were no ED visits or hospital admissions in this healthy elderly group, but in those that were in the high-risk group, so those with underlying comorbid conditions, the medical resources were much more frequently accessed, where 23% called their doctors, 29% made some kind of office visit, 9% needed to go to the ED, and 16% required hospitalization. And 2, which is about 4% of those patients with high-risk features with RSV infection died. Those with RSV also were not able to perform normal activities of daily living for at least 1 day, regardless of them being healthy or not. And not surprisingly, the proportion of patients who had acute functional impairment was significantly greater in those with high-risk features compared to the healthy elderly group. The impact of RSV for morbidity, mortality, and post-discharge care is also shown in this study. So this is a retrospective cohort study that included all adults, so that's anyone over 18 years old, with a positive RSV test admitted to the hospital. And this is a study conducted over 6 years in Chicago. During the 6-year study period, close to 500 patients were hospitalized with RSV. And consistent with the prior studies we've discussed, most of these patients with RSV had a history of at least one medical comorbidity. And when I say most, it's 93%. Severe disease was documented in close to 30% of these patients. And while most patients were discharged home after their median hospital length of stay at 3.6 days. Close to 13% were discharged to other medical facilities. So this includes rehab centers or skilled nursing facilities at a median length of stay 11.6 days, so significantly longer. Close to 4% of patients died after a median length of stay at 16 days. And finally, co-infection can be very common among adults with RSV infections. It's reported that 12.5 to 23.4%, depending on the study that you're looking at, have bacterial co-infections, and close to 22% of patients have viral co-infections when they have RSV. This is a retrospective study that was conducted in France. All adult patients hospitalized with RSV from February 2014 to April of 2019. And again, many of the patients admitted, not surprisingly, were elderly with a mean age of 69.9. If you look at the global in-hospital mortality, it was 1.4%, and the mean age of the patients who were deceased was higher than those admitted at 80.6 years. The majority of the deaths, actually, close to 98% of deaths, occurred in patients who were over 65. But if you're looking at the co-infection rates, so bacterial co-infection was detected in 12.1% of patients, and the crude in-hospital mortality was significantly higher in patients who had RSV and bacterial co-infections if you compare it just to RSV acute respiratory illness alone, with a hazard ratio of 2.7. And this finding remains significant even after you adjust for age and length of stay at a hazard ratio of 2.94.
Thank you, Dr. Nam, for presenting that. Now I'd like to pose some questions for you and Dr. Ison. How do you perceive RSV in your patients greater than 60 years of age, and why?
Those over age 60 do tend to be at an increased risk for hospitalization, as well as death, unfortunately. And the older your age gets, the risk does increase as well. A lot of the risk profile that you have to consider as well depends on the comorbidities of the patient. So anyone with lung disease or heart disease, you tend to worry a little bit more that they're going to have worse outcomes when it comes to RSV.
Yeah, I think the other area where I get concerned is in patients that are debilitated, people that are in nursing homes, rehab facilities, those kind of things. I think that they have a lower reserve and have a harder time recovering. They're more likely to get hospitalized and more likely to die from RSV.
How did COVID-19 affect your perception of RSV in your patients?
I think the biggest challenge with COVID-19 is that we had really low numbers of RSV. And so I think most clinicians, myself included, didn't even really think about it as a major problem. I also think that many of our testing strategies have been hyper-focused on COVID-19, and we may have missed some of these cases. Our protocol here is that patients with respiratory symptoms get COVID testing. Once that's negative, then additional testing can be ordered on the patient. Problem is that means 2 trips in, and most of the time the testing didn't get done. So I think we missed a fair amount of cases. The good news is, as we'll talk about in a few minutes, I think with a greater push towards diagnosis of patients presenting with respiratory viral infections, we hopefully will recognize more of those patients because they'll get tested now that we have platforms that can look for various infections.
What are your perceptions of the clinical differences between RSV and influenza in your patients?
Yeah, this is an interesting question. There are a few studies that show that clinician perception tends to be that influenza is a much worse disease when you compare it to RSV. But I really do think a lot of this depends on the underlying comorbidities that the patient has. If you're looking at just the symptoms that the patients have, RSV tends to have pretty clinically indistinguishable symptoms with other respiratory viruses, and that includes flu. The main difference I would say is RSV tends to have a lot more congestion compared to flu, while flu tends to have a lot more myalgias and higher rates of fever. But other than that, many of the symptoms tend to overlap.
What percentage of your symptomatic patients greater than 60 years of age are you likely to refer for RSV testing?
Yeah, I think that that's something that's changed a lot during the pandemic. I think in 2019, a lot of the patients would just say, if you don't get better, come on in for testing. But a lot of those patients wouldn't get tested. Patients in nursing homes or with other exposures to at-risk patients were more likely to get treated. Patients that came into the hospital or had failure to improve with kind of initial therapy or more likely to get treated. But I think now we have a lot of systems in place to get these patients tested, because the big fear is, do they have COVID, since you can't really differentiate the two. I think the real limiting factor is going to be, how is your practice set up to be able to do that? Again, I think a lot of places are really still primarily testing for COVID in symptomatic patients and then kind of leaving it up to the provider to ask for additional testing. I suspect once we move into the flu season, as this will probably be the first flu season with pretty significant co-circulation of the viruses, we'll quickly adopt an approach where our diagnostics are looking for multiple pathogens in these patients presenting. And I suspect we'll have more of those patients referred in for testing.
Are you more likely to refer certain patients for RSV testing, and why?
Yes, so a lot of the patients we have that are elderly and have some kind of respiratory symptom, and especially with lower respiratory symptoms where they're actually like coughing, wheezing, and on the worst spectrum have hypoxia. Those patients do tend to get tested for not just RSV, but flu, and as Dr. Ison mentioned, COVID as well. And a lot of it has to do with the underlying risk that the patient is going to progress to severe illness. And some of it is a predictor of whether or not the patient is going to need an inpatient hospital stay as well.
Great. And now we'll move on to Dr. Ison, who will discuss diagnosis.
Great, thank you very much. So before we start talking about diagnoses, let's start with a case. This case is Oscar, who's a 69-year-old gentleman who's presenting to his primary care doctor with a low-grade fever, 37.5, fatigue, chills that began about 6 days ago. When he presents to you, he complains of congestion, severe runny nose, cough, sore throat. All of these started to develop 3 days ago, along with the onset of fever. He's been unable to sleep, has really not gotten a lot of relief with over-the-counter relief medications. On exam, his temperature is 37.8. He has productive cough and decreased breath sounds with wheezing and crackles and rails bilaterally. His past medical history is consistent for a BMI of 27.7. He has type 2 diabetes, coronary artery disease, and hypertension that's controlled with medication. So I think the question to you is, what is your clinical assessment? Does this patient have flu, RSV, COVID, or some other infection? What testing would you do, and would you specifically look for RSV? Are there specific tests that you would prefer over others? We'll come back with some of those answers after going through some data. So let's talk a little bit about diagnosis. We have a number of different methodologies that can be used to diagnose RSV and other respiratory viruses. These include serology, which generally isn't used clinically, cell culture, again, not commonly used in current clinical practice, but rapid antigen tests and direct fluorescent antibody tests have been done, although less likely, as I'll talk about in adults. Rapid molecular and multiplex PCR or molecular tests are more commonly utilized in this patient population. Let's first talk about rapid antigen detection tests. They have a real advantage of getting you a result very quickly. I think patients and providers have become much more familiar and comfortable with these tests with the advent of COVID antigen tests. The challenge is, unlike COVID-19, the sensitivity in adults is relatively poor, anywhere from 11 to 48%. So you're more than likely to have a negative test and still have RSV than to have a positive test with this testing platform. The advantage is, if it's positive, it's got great specificity, and so it's more than likely that the patient actually has RSV. The second option is direct fluorescent antibody testing. These really require experienced labs and specific fluorescent antibodies for testing of primary specimens. They have to be sent to a lab, so the turnaround time is a little bit longer. The sensitivity ranges anywhere from 23 to 74%, definitely better in general than the rapid antigen test, but again, really requires an experienced technologist, appropriate controls to make sure that the antibodies are working appropriately, and so more likely to result in false negative results. If positive, it's most likely truly RSV, and you can react to that. But particularly with the advent of the COVID pandemic, we've moved into an era where most laboratories have moved to molecular diagnostics, and there's basically two flavors of these that are available. The first is rapid molecular testing, and these typically look for either RSV alone or more than likely combination tests. Typically, COVID, RSV, and flu tests, they may not give you the same degree of information of a broader multiplex test, but they can give you results sometimes very quickly in as little as 20 to 30 minutes, but sometimes, particularly if they have to be sent to a central lab, may take 1 to 2 hours. They have really good specificity that range from about 90.6% to 97.9%. I think one of the biggest things, just like all of our diagnostic testing, is the quality of the specimen collection is really probably the most important part of the sensitivity. These tests have incredible specificity, and really, again, if the test is positive, the patient more than likely has RSV. Lastly, kind of the gold standard that is oftentimes used in the hospital-based setting are the more complex multiplex molecular tests. These have to be done in a lab. They take a longer time for turnaround, although again, with a lot of technology advancements with COVID-19, turnaround times have really dropped very quickly. These likewise have the challenge of making sure that you have a quality specimen, and rarely, up to about 20% of the time, the patient may have an infection, but it may not be detected in the upper airway and require lower respiratory samples to be collected. The sensitivity of these assays are pretty close to the rapid assays, somewhere between 90 and 98% sensitivity. Specificity, again, really excellent. So if you have a positive result, you can depend on the fact that the patient has RSV. So turning back to our case of Oscar, I think the real challenge with RSV is clinically, it's quite challenging to differentiate RSV from other respiratory infections. The fact that this has been going on for 3 to 6 days makes it a little bit less likely that it's RSV, but it sounds like it's gotten worse with emergence of fever. So still definitely in the differential diagnosis. Flu typically is associated with a much more rapid onset, although again, older adults may be less likely to have high fever, sort of like we're seeing with Oscar. As a result, I would really want to do a diagnostic test that looks for a range of pathogens, and I think it would depend a lot on where I was and what were the capacities of the clinic that I was working in. Ideally, I would want at a minimum to test for COVID, flu, and RSV, and use ideally one of the rapid tests, because that would give me an answer very quickly about the appropriate information from that test. It would allow me to then have actionable results that I can lead on. So I think we'll turn it over to you, Dr. Nam, and we can talk through some other challenging questions.
Yeah, I had a few questions for you. So are there any factors that prompt you to test for RSV in your symptomatic patients who are over 60 years old?
Things have changed a lot, I think, with the COVID pandemic. Many providers, particularly if they didn't have ready access to testing, if someone was relatively mild and doing very well with not a lot of underlying medical conditions, may have deferred on testing. I think a lot of those patients will now get tested to make sure that the patient doesn't have COVID-19. And I think particularly if you know that there's RSV circulating in the community, ensuring that you screen for a broader range of tests, I think, is important. I would definitely want to test patients that have underlying lung disease, severe cardiac disease, or are deconditioned in a facility where they may expose other patients, such as in a nursing home.
What diagnostic method for RSV do you prefer and typically use in your patients who are over 60?
Yeah, I actually think this is really, not so much what I favor, but what's available. I think if I had access to a rapid diagnostic test that would allow me to screen for COVID and RSV in the same test, that would be what I would choose. If that isn't available and there's only, for example, rapid COVID testing available, I'd probably do that. If negative, then collect a multiplex to send off. As I kind of mentioned before, I'd probably be more likely to do that in patients that have greater symptomatology or have one of the risk factors.
Along those lines, if you do have a RSV test that is positive in, say, a patient who's over 60 years old with respiratory symptoms, does that change your management, or what kind of impact does that positive test have?
Yeah, I think that's a great question. I think the biggest utility is it's a great tool that I can use to talk with the patient about the fact that I found this virus. It's unlikely that they're going to have bacterial superinfection and that they probably won't benefit from antibacterial therapy, and that those antibacterial therapies, if I gave it to the patient now, probably are more likely to cause side effects, cause things like C. diff or resistance in the patient for when they had challenges with bacterial infections in the future. Hopefully in the near future, we'll have some drugs that are available to treat some of these infections, and that may help. I think it would also, particularly if patients had respiratory symptoms like Oscar did, to prescribe bronchodilators or other inhaled medications to help them transiently over their acute illness and help them feel better. Additionally, I think it gives me the ability to talk to the patient about the expected timeline of this infection, that most people get better, but if they start having worsening symptoms, then that would be something for them to reach out and follow up with me. Well, I really want to thank Steve and Hannah for spending time talking with me today and talking with you about RSV. Thank you for joining us. Please make sure to claim your CME credits by completing the post-test and evaluation forms on the link on the screen. And make sure you follow Bonham CE on Twitter to stay tuned for more RSV content.